My name is Anil Trindade. I'm a transplant pulmonologist at Vanderbilt, and it's really an honor and a pleasure for me to be here. This is actually my first time at the Pulmonary Fibrosis Foundation Summit, and I'm really excited to be here with you all, with a really interested and captivated audience. So hopefully this will be really helpful and prompt some conversation and discussion. Really looking forward to getting questions and answers. So the title of my talk is To Transplant or Not to Transplant, and it's really taking us down the pathway of if we feel like transplant is something that might benefit a patient, what are the roads ahead looking like, and conversely, if transplant's felt to not benefit a patient, then what happens after that. So these are my disclosures and funding sources. Nothing that I'll be talking about today poses a conflict of interest. So to start, I'm going to discuss why we perform lung transplantation. So what are the goals? What do we hope to achieve by performing a transplantation? Because then hopefully that provides some background for you to understand why we make the decisions that we do, okay? We'll then further discuss some challenges and risks associated with lung transplantation, and then I'll finish up by talking about the fork in the road in terms of if somebody's a candidate, what are the next steps going to look like? Conversely, if we feel like transplant may potentially harm a patient, what happens then? So to start, I don't know if you guys know I'm a big history buff, and so I think the history of lung transplantation is quite fascinating. So the first lung transplantation was performed at the University of Mississippi in 1963 by this gentleman pictured over here, James Hardy. And I won't go into too much about the characteristics of the patient and the procedure, but suffice it to say, at that point in time, it was very much an experiment. And there were a lot of things that happened to that patient that an institutional review board probably wouldn't allow nowadays. Suffice it to say that the patient lived for 18 days, and I think the most interesting aspect was that despite us not having the immunosuppression regimen that we use nowadays, the patient survived for 18 days, and what they died of was not rejection, which is what everybody assumes. It was actually kidney failure. So you can see that since then, lung transplantation has just exponentially grown. And what I tell patients and students and whatnot is that the field of lung transplantation is actually relatively young. It's about 40 years. And you can see that the first real serious transplants started to occur right in the late 1980s. And it really started to explode in the late 90s and early 2000s. Somebody will get a cocktail on me if they can answer, why did it take so long for lung transplantation to start? What happened in the 1980s that allowed for lung transplantation to become a field? Does anybody know? Just shout it out if you do. No, so that's a great guess, but I guess I'll be drinking by myself tonight. So it was actually the advent of immunosuppression. So cyclosporin was discovered in I think 1973, don't quote me on that, but it was in the sort of mid-1970s, and that really introduced the class of anti-rejection meds called calcineurin inhibitors, and that's really the mainstay of immunosuppression, and in fact we use tacrolimus as the preferred one today, and that allowed for lung transplantation. The other thing that really allowed for the field to take off was refinement in surgical techniques, because before the anastomosis, or the connection between the old lung and the new lung at the airway, would just simply collapse, and people would die from infections to the mediastinum, the middle portion of the chest. So really, refinement in surgical technique and immunosuppression allowed the field to really take off. And to the point where today, we're now performing about 5,000 transplants per year around the world. The majority of those in purple are bilateral transplants, where we transplant both lungs, and then in green are the single lung transplants. Why do we perform lung transplants? So this is a discussion I have with my patients at least 10 times per week. So who do we transplant, first of all? Transplantation is meant for patients with advanced lung disease, which I define as a progressive, irreversible lung disease, and that's despite optimal medical therapies. So for patients with interstitial lung disease, generally they're on antifibrotics. And it's for those patients whose expected survival in the next 2 years is less than 50%. And so for those patients, lung transplantation can afford two things. One's an improvement in quality of life, and the other is an improvement in survival. And studies show we can, again, do both of those things. This is an older slide, but I still like to show it because I think it's kind of fascinating. It reveals two things. So this is a study over a 25-year period looking at outcomes for patients who are added to the waitlist. And it's for all different types of organs, so lungs, kidneys, liver, and heart. So there were patients who were added to the waitlist and not transplanted, and it's, I think, hard to see there, but the average survival for those patients was just about 2 years, which is where we get the survival benefit of having to be greater than 2 years for a transplant to be worth it, right? And for those patients who were transplanted, median survival at that point in time was about 5 years. So you guys have a chance to redeem a cocktail on me. If you can see in that blue box, median survival, average survival for at that point in time for kidneys, liver, heart are all about 10 years plus. But median survival for lung at that period of time was just half of that. Any guesses why? Yeah, you take a deep breath, you're inhaling dust, you're inhaling viruses, microbes. So we think that the lungs have this low grade, and sometimes not so low grade, activation of pro-inflammatory mediators that can lead to rejection and ultimately chronic rejection. So I think 3 of you get a cocktail on me, come find me later. Median survival, fortunately, has improved over time, and that's because of our surgeons having better technique. We're able to identify better donors and preserve those lungs in a better way. And physicians like Dr. Dilling and myself are able to take care of infections and other complications. So median survival is now shifted from about 5 years to now closer to 7 years. And by the way, anytime I throw a number out at you, remember that's an average, so there's a range, right? So we have patients, actually the longest living lung transplant survivors at Vanderbilt, one of our patients. She's living 34 years after transplant, and she's still alive. 34, yeah. Now, one of the fascinating things about this curve, though, you might say, those curves actually look fairly superimposable, right? And if you look closely, the biggest difference in those shapes of the curves is really within the first 1 to 2 years, suggesting that our improvement in survival is because of things that we're able to accomplish early post-transplant, but causes of death that affect our recipients later on are pretty much the same. So your next question might be, well, what causes mortality early on versus later on? And so if you look at this graph from the ISHLT, which is one of our large bodies in the heart-lung transplant world, this is a registry study showing that the number one cause of mortality early on, so before that black arrow, is in that blue line, which is infection. But after the first year, the number one cause of mortality is the onset of chronic rejection, or CLAD, chronic lung allograft dysfunction. And sorry, some of my slides aren't showing clearly, but that's what that red bar is. So what is CLAD? And I'm just trying to introduce you to some of the terminology. A lot of this obviously is not so important to you guys now. But this is an image, a cartoon of a normal lung. And we know that patients can be exposed to lots of different acute insults, right? So there's something called primary graft dysfunction early on, inflammation within the first few days, infections like respiratory viruses, reflux, acid reflux, so the acid and the bile salts can actually injure the lungs. So over the life of a lung, people can be exposed to repetitive injury events. And these injury events can cause inflammation, as we talked about a little bit earlier, and that can lead to scarring of either the airways or the walls of the alveoli. And that's what we believe a model of chronic rejection to be. All right, so with that in mind, with that background, I thought we could, one, just talk a little bit more about some of the risks of transplantation, and then talk about steps in the transplant process. So lung transplantation is a multi-step process, and this is looking at just the early days in terms of procurement and implantation. And one of the biggest things to understand is that these lungs are coming from donors who are sick, right? They're dead. They died of something. And so a lot of these donors are intubated, they're on mechanical support, often for days, and so the lungs are colonized with different kinds of bacteria and other things. The act of removing those lungs and storing those lungs can take a long period of time, and these lungs are stored under harsh conditions, sometimes at 4 degrees. We now know that warmer temperatures, so up to 8 to 10 degrees centigrade, are a little bit better. But these lungs are pretty beat up, right? And then you have the several hours long surgery and procedure to actually implant those lungs. So by the time you actually get your very first chest x-ray, this is not an uncommon sight where you see just a lot of inflammation that may take days to recover from. So the early parts of lung transplantation can be, pretty involved. And on average, patients in the ICU, in the intensive care unit, for about a week, if not longer. And remember, the sicker you are going into a transplant, the sicker you are coming out of it. Average total hospital length of stay during that first, what we call the index hospital stay, is on average about 3 weeks. And these numbers are coming from my center at Vanderbilt. And then the last picture is our goodbye present that we give people, which is, it looks like a fishing tackle box, but that's their medicines that they take, right? So you can see that this is a pretty involved process. And a lot of, when I counsel patients, I think a lot of angst with transplantation really is around and surrounding the surgery. And what I tell people is, at least at our center, we have 100% survival since I've been there. I'm not a surgeon, by the way. So really the hard part about transplantation is the fact that people are exposed to anti-rejection or immunosuppression drugs. And I kind of make the analogy that these are equivalent to chemotherapy in the sense that if you're a cancer patient, these are life-saving medications, but chemotherapy is pretty toxic. And that's the same with these anti-rejection medications. I'm not going to go through all the complications, but you can see that it's basically a head-to-toe sort of involvement in terms of things like headaches to infections to kidney damage. It's a lot. And lung transplantation, what I also tell patients, it's a lifestyle. There are lots of things that we ask our patients to do. And there are also lots of things that we ask our patients not to do. So if you're a sushi lover, sorry, California rules for you only. If you're a grapefruit lover, sorry, that can impact the metabolism of tacrolimus, which is the main anti-rejection medication. I like to tell folks, I brag that our patients are the original maskers, right? We made masking a cool thing because you don't want to get infections. And then other ways of preventing infection, vaccines, hand washing, et cetera, et cetera. We encourage our patients to exercise every day, and then we transplant people so they can live their life. So that's what we encourage patients to do. So preserve your mood, make life worthwhile, get a hobby, volunteer, whatever makes your life worth living, please explore that, either before transplantation or after. All right, so what if we feel like lung transplantation is potentially harmful? Now remember, we all took the Hippocratic Oath, which sometimes we summarize as first, do no harm. That's one part of it, right? And in the wrong hands, if we were to transplant, I hear from patients a lot, what do we have to lose? Just transplant me. And one of the things that can be almost worse than death is transplanting somebody who we know would be a poor candidate, meaning that they would not only not benefit from transplantation, but it would be harmful. And you can see that in the wrong hands, for the wrong patient, transplantation can lead to prolonged times on the ventilator, right? If somebody's frail going into it, they're likely going to be unable to breathe, they'll be trached and on a ventilator for a prolonged period of time. If somebody's predisposed to infections, they might get lots of infections and inflammation of the lungs. The surgery can impact the vagus nerve and can cause something called gastroparesis, where the stomach doesn't contract. If somebody already has pre-existing reflux on top of that, oftentimes we feed them through a tube. And that's, for me, who loves cocktails and food, that's not a life worth living. But everybody has their own ideals. And then certainly we know that these medications can cause kidney disease, they can lead to cancers, et cetera, et cetera. A lot of times we get asked, what are the absolute contraindications? We as a field are really getting away from that. And what we're really looking at are what are risk factors and what's an acceptable risk for the patients and what's an acceptable risk for the transplant center. And so these are some of the things that we look at Vanderbilt. Some of the different centers have different criteria. I won't go through all of these things. We ask for caregivers. It's really hard. You can't drive for the first few months after transplant. A lot of our patients are frail. You certainly need support, and without caregivers, things go downhill pretty quickly. So that's one of our must-haves. I have malignancies here with asterisks, meaning that for a lot of cancers, the adding immunosuppression, anti-rejection meds into that milieu creates an environment that allows cancers to thrive. But I have the asterisk there because we're now reevaluating. Not all cancers are created equal. Some aren't really immunogenic. And so in the face of immunosuppression, those cancers don't tend to grow, prostate cancer being one of them. And then, we used to say the perfect candidate is one who has single organ disease, so respiratory failure only. A lot of centers, ours included, are now looking at combined organ transplants, so heart, lung, heart, liver, but that's in the ideal candidate, right? One of the things that I do tell people is to, take a second look at another center if the first center has news that you may not want to hear, right? Or if you think you might be a candidate elsewhere, take a look. And there's a website, the SRTR, Scientific Registry for Transplant Recipients, that lists all the transplant centers and has different ranking systems. I highly encourage you to take that, though, with a grain of salt, because if you look at that first, and I know this is hard to read, I apologize, but one of the first metrics is waitlist mortality. You might say, well, I'm not going to go to Vanderbilt, their waitlist mortality is high. And that's because we take a lot of risks. So we transplant a lot of patients that other centers wouldn't, and therefore those patients might be dying at a higher rate on the wait list. We're also transplanting really quickly, so our patients aren't on the wait list for a long period of time. All this to say is, take things with a grain of salt. Not everything is what it appears to be. Two other things to just talk about a little bit. Body mass index is one of the criteria that a lot of transplant centers take into consideration, and that's based on data showing that extremes of body mass lead to increased risk for post-transplant mortality. So if you're underweight, that's one of the characteristics of frailty. Obviously, we don't expect those patients to do well. If you're overweight, that creates challenges both in terms of healing as well as a protuberant abdomen can push up on the diaphragms and prevent proper lung expansion. And then age. That's, as our population is aging more so, a lot of centers, including our own, are taking risks in transplanting people in their early, mid, and even late 70s. This is a slide looking at the impact of center volume and age. And suffice it to say, yes, people with older age don't live as long. Center volume doesn't tend to change that impact. Does that mean we shouldn't transplant people who are older? Not necessarily. I think we just shouldn't have the same expectations for 7, 8, 9, 10-year survival. All right, so one of the questions that we get, and I think one of the hardest conversations that I have with patients is when we have to sit down and say, listen, we don't think transplant's right for you. We think it's potentially harmful. And it is a very difficult conversation, but we're doing what's right for the patient, what we feel is right for the patient. So what are the alternatives? What are things if you or a friend are told that transplant's not right for you, where do you turn to? And there are other things that you can try. So one is, optimizing standard of care therapies, right? So, I think one of the themes here is that there's a new antifibrotic agent that's on the market as of a month ago. So there are other therapies that are becoming increasingly available. There are a ton of clinical trials, and I'm sure those are being presented at this meeting. I believe there are at least 10 active clinical trials at our center alone, and that's true at many of the centers around the country. Other things to look at, just ways of better supporting gas exchange, whether that's higher levels of oxygen, whether that's non-invasive positive pressure ventilation, so CPAP or BiPAP. Those are things that you can discuss with your pulmonologist. Pulmonary rehab, whether transplant is in your future or not, helps build your muscles of breathing, decreases the sensation of shortness of breath. And then palliative care is something that I hope is being discussed at this conference. This is a branch of medicine focused on symptom relief, right? So whether transplant's in your future or not, palliative care is something to consider. And then, one thing that we all have to deal with is planning our future, right? Whether that's end-of-life care or not. The one thing that you don't want to leave is a mess in terms of a financial mess or not having your wishes respected, right? Both for end-of-life care from a health standpoint as well as a financial standpoint. So certainly be proactive about putting your affairs in order. What if transplant is in your future? So one of the next steps, the first thing you would meet with a physician like myself or Dr. Dilling. We talk about the pros and cons of lung transplantation. If you wanted to move forward, and we felt that based upon the information we know at that point during that initial meeting, things looked favorable, then we would start with an evaluation. And that's basically a head-to-toe exam, an in-depth exam, to make sure that all your other organs are functional to not only survive the surgery, but to survive many, many years in the setting of anti-rejection medications. I don't expect you to read that to the right. That's what our transplant evaluation workup looks like. So it's lots of different serologic studies, so blood work, imaging studies, CT scans, invasive things to look at pressures in the heart to make sure that your coronaries are clean, colonoscopies, all those things. My biggest advice, make sure that you're up to date on all your usual standard of care screenings, right? Cancer screenings, eye doctor, dentist, make sure you're up to date with all of that. The next step, once you've completed the evaluation, which at our center on an outpatient standpoint takes about 1 to 2 weeks, we meet as a committee. So our selection committees are, every Friday morning, it happens to be. And this is an example of what it looks like. So ours is through Teams. There's some vestiges of COVID that haven't moved on. But most importantly, this is multidisciplinary. So you have surgeons, you have pulmonologists, you have psychiatrists. Our selection committee is about 80 people. So it's not just one person thinking about your future, it's 80 people thinking about your future. And the big question we ask is, will you benefit from lung transplantation, right? It's not a beauty contest. Is this going to be a helpful therapy? Assuming that it is, patients are then on the wait list. Average wait list time around the country is now 1.6 months. Yeah, I see a lot of people in shock. So it's not years, what people think. It's literally now weeks. So certainly get your affairs in order if transplant's in your future. There are certain determinants, so there is a range, so blood type compatibility, height, and then there is a priority score that tries to make things a little bit more equitable in terms of the order of priority that patients receive and offer. So a quarter of that is based upon expected survival on the wait list. Obviously, we want to transplant people who are sicker, so they're not dying on the wait list. A quarter is also expected survival, though, 5 years after transplant, because we want to make sure that those patients that we're transplanting will actually have a benefit. And then there are a few other considerations that go into that composite allocation score. The only other thing that I wanted to talk about quickly is the concept of the dry run. And I think this really concerns patients at times. So why do I get an offer? Why do I get called into the hospital only to then be told, oh, sorry, those lungs weren't that great? And this is just to highlight that there's a lot of coordination that goes on to identify the correct donor and also to prepare the patient. So just focusing on the top row there, once we hear about a potential donor lung, our team, and some of the criteria seem to be okay, our team flies out to the donor hospital. We assess the lungs, so there's a bronchoscopy that's done first to make sure there are not a lot of secretions. The donor's opened up, the lungs are palpated and inspected, they're then removed. And anytime during that point of time, something could come up where we say, well, these lungs aren't usable. Once those lungs are accepted, then they're flown back to Vanderbilt or whatever center. And remember, sometimes we're procuring lungs thousands of miles away, so that takes time. We're trying to minimize the time that that lung is without blood flow. So concurrently, we're also preparing the recipient. And remember, we have to screen to make sure that the recipient on the wait list didn't acquire COVID or some other bad infection. We have to make sure all their blood work is up to date. And then those lungs, if it's a go, then the recipient is opened up, their lungs are extracted and removed, and so once that plane lands, there's a minimal amount of time to sew those new lungs into that patient. So again, sometimes this, especially on the donor side, doesn't work out well, and so we say, sorry, wait until next time. We're waiting for the perfect match. So hopefully this was helpful in terms of giving you an understanding of why we do lung transplantation in the first place, explaining some of the challenges and risks associated with lung transplantation, and then talking about sort of the steps of whether transplant is in your future or not. And I'm happy to take questions at the end. Thank you very much.
All right. Well, thank you very much, Dr. Trindade. That was a terrific framework for this panel discussion and conversation around transplant. My name is Dan Dilling. I work at Loyola University Medical Center here in Chicago, and I'm working the transplant team and ILD team there. I'd like to introduce our other three panelists to you. And so on my left is Karen Smoot. Karen was diagnosed with idiopathic pulmonary fibrosis in 2011 and 2019, and she was diagnosed with pulmonary arterial hypertension related to IPF. She is a Pulmonary Fibrosis Foundation ambassador and one of the authors of plain language summaries for the PFF and United Therapeutics on articles related to medication that she is currently taking for both conditions. Over the last 10 years, she's facilitated an IPF support group and is very familiar with the treatment and emotional issues faced by group members who are at various stages in the disease. Karen attributes her longevity and continued quality of life to having purpose and to her dedication to volunteering. She was named the 2025 Volunteer of the Year for the city of Albuquerque. Karen retired as Divisional Vice President of Network Management for Blue Cross and Blue Shield of New Mexico in 2016, where she was responsible for developing and maintaining a broad network of hospitals, physicians, and ancillary providers on a statewide basis. She developed innovative managed care contracting strategies and implemented healthcare reform policies related to the provider network. In her capacity with the network, Karen contracted with durable medical equipment, or DME companies, that provide contracting requirements and challenges of these organizations, that provide supplemental oxygen and supplies. So she's familiar with contracting requirements and challenges of these organizations. As a support group leader, she's also aware of the access problems related to oxygen supply and clinical support, and continues to advocate for the passage of the Supplemental Oxygen Access Reform, or SOAR Act. So welcome, Karen. On her left is Gary Johnson, who is from Baltimore, Maryland, but currently resides in Upper Marlboro, Maryland. He's married to Renee Johnson for the past 32 years and has 3 children and 4 grandchildren, and still works full-time as Senior Business Development Director for a national healthcare organization. He graduated from Iowa State University back in 1987 with a BS in broadcast journalism. He's a former television news anchor for the Central Iowa region, celebrated his 60th birthday on September 26th, and his wife surprised him with a trip to Singapore and Bali. His wife, the two of them enjoy international travel all over, and the past few years have also gone to Egypt, Greece, Venice, Paris, London, Rome, Madrid, Barcelona, and other amazing locations. He's very active in his local church and community and loves the Lord. He's a member of the 2024 Transplant Ambassador class, and on December 1 of this year will be his 5-year anniversary of transplant. And he was transplanted at Inova Fairfax Hospital in Fairfax, Virginia. And so he's an IPF patient and survivor. On his left is Anita Close, who is from Ann Arbor, Michigan, diagnosed with pulmonary fibrosis in 1994 due to hypersensitivity pneumonitis. 22 years after that diagnosis, she received a double lung transplant in 2016. She supports others with pulmonary fibrosis and lung transplants and shares her personal experiences as a PFF ambassador. She also serves as a PFF advocate and has met with her members of Congress during the PFF Hill Day to advocate for research funding for PF and supplemental oxygen reform. Advocacy and sharing information, as well as providing peer support on this unplanned journey, is important to Anita regarding PF organ donation, aging, healthcare, and other issues that are now so very personal. So over a long career, Anita was a medical social worker and a social work administrator at several hospitals, and an adjunct lecturer at the University of Michigan and Eastern Michigan University Schools of Social Work. With oxygen as a fashion accessory, she was married 2 months before her transplant and has 2 very grown adult children and 5 beautiful grandchildren. So welcome all 3 of you to our panel, and with that, maybe each of you could maybe give a little bit of perspective of life, and maybe a wise way to do this would be maybe think about some of the things that we already heard in the slides and bring them to life. Like, sort of how true were those things that he said? Are there any things that you'd maybe spin a little different way? And maybe what are some of the most important messages to, like, really hammer home here?
Okay.
And you can start, yeah.
Okay.
Yeah, if you turn the green light on, you should be able to be heard.
Green light's on. Thank you. Can you hear me? Yes. Good. You know, those of us with IPF or scleroderma or any of the related ILD diseases, we make decisions all the time. We're always faced with decisions. Should we continue to work? What's our exercise schedule look like? Should we walk the dogs? What medication should we take? What treatment plan should we get on? What clinical trials should we want to get involved in? But one of the most difficult decisions is that about, should we have a transplant? So I would like to talk to you about my decision not to have a transplant, why I didn't want to be listed, nor evaluated, nor considered for a transplant. In 2011, I was diagnosed with IPF, and I continued to work until 2016. So I had all of those other symptoms, fatigue, and all of the other symptoms that we go through with IPF, but nothing so severe. And my pulmonologist, after a few years, it wasn't in 2011, but after a couple years, he suggested I be listed on the transplant list. And I immediately said no. Well, he was trying to explain that even though he didn't think that I was a candidate at that moment in time, he thought I should be evaluated so that I could determine if there were any other comorbidities or anything that would prevent me or could be resolved before I was really eligible for a transplant. I continued to say no, but I said no without very much information. I thought at that time, I'm too busy for a transplant. I had too many things to do. I couldn't spend time having a transplant. And then for several years after that, because I facilitate a support group and have for well over 10 years. So I've had many people in my support group who have been evaluated. Some have had transplants. Some have had very successful transplants. Some have had a lot of infections, and a few people in the group died, not as a result of the transplant, but after the transplant. And so I started to consider, I gained a lot more information about why I was making that decision. And when I found out more about the whole evaluation criteria, and if you did not have a caregiver and that would, or someone that would be by your side 24/7 for at least the first 3 months, and if not the next 6 months, then you would not be considered a candidate. So when I look, and another thing, I'm from Albuquerque, New Mexico, and we don't do any transplants in New Mexico, any lung transplants. So the closest place that I could get a transplant was going to be Phoenix in Arizona. And so I considered that the distance, that there's several people that were in the support group that had received a transplant in Arizona. There were, of course, bumps in the road, as any of you who have had transplants know, and considered those, but they had to continue to go back to Arizona every time there was a problem. And so, but one of the major reasons is that I've lived by myself for 30 years. And I'm really content to live by myself. But I don't want you to misunderstand that I don't have a lot of caregivers. I have people that definitely care about me. I have a son that lives 5 minutes from me that has a marvelous wife that is devoted to help me out when I need it. I have a great grandson. I have many, many girlfriends in all different areas of book clubs and girls' night out groups, and I also have 7 brothers and sisters, and they have also made offers. They all live on the East Coast, but they have made offers to help me if I needed it. And I even have 2 ex-husbands who have committed if I needed them to come. Now, of course, I did not ask them if that commitment was shared with their significant others, but I'm hoping that at some time they would tell them. And so that, in combination with some of the restrictions that not working in the garden and being much more careful about being around large groups and wearing a mask when you were in large groups, and the defining factor was that I could no longer have that glass of wine when I wanted it. So I really made a decision and cemented that decision over the course of these years. And the reason I say that is sometimes it's easier to be confirmed in your decision as you get older. And there's a risk in that too, because if you decide you made the wrong one, then it's harder to get accepted somewhere. If you've made, and right now, and I will be 80 in 6 months, and so there are some transplant centers that wouldn't even consider me, but I made these decisions more when I was in my late 60s, and I still feel very good about that decision. And when I said that sometimes it's easier as you get older, it's just that those things that would influence you, because getting a transplant is a very personal decision, despite the fact that if you have a significant other, you share that and you make that decision together, and your children and your grandchildren have influence on that decision. It's still a very personal one. You are the one taking that risk, and you are the one that are going to benefit or suffer any consequences from that decision. So it has to be ultimately your decision. And in growing older, those reasons why I would have done anything to prolong my life, some of them are resolved now, really. My oldest son, who used to live with me, so I had 5 dogs at that time, and when my oldest son lived with me, I was worried that he wasn't going to do well, and he wasn't working, and now he has a marvelous husband and lives in Palm Springs, and so I don't worry about him. The other son has always worked and has a marvelous wife, and he's doing great. And my grandson, I have one grandson that I thought, I need to see this young man get older. I didn't expect that I would see him get to be 40 or 50, but I wanted to see him get older. And he is now graduating. He was in middle school when I was diagnosed, and he's now graduating UNM in civil engineering in December. So he's taken care of too. So I just wanted to share with that, those are my personal decisions. Some of those may apply to you also, but it's very important to consider all of those before you make this decision for a transplant. So thank you.
Thank you for sharing those really wonderful perspectives. Gary, I think you have some slides as part of your talk, and I can't wait to hear the TV voice, by the way.
All right, so as you all know, my name is Gary Johnson. It was mentioned before in my intro that 17 days from now will be my 5th year post-bilateral transplant anniversary. It's a big moment. And for me personally, it's interesting to see, kind of tying back to some of the facts and information that the doctor gave earlier and some of the other sessions that I've attended, But back 5 years ago, even 6 years ago, much of the studies were, not as advanced as they are now. The big thing that we heard over and over, 3 to 5 years you got, on average. You'll be dead in 3 to 5 years. Not quite presented like that, but that's what I heard. So I'm in sales. I've been in sales for a long time, and I'm very competitive. And December 1st is 5 years for me. So that's a big thing for me. And over Fairfax Hospital is where I had my transplant, I'm IPF, not just a patient, but a survivor. That's very important for me to recognize. My wife is a 2-time breast cancer survivor. Not only are we surviving, but we're thriving. And that's very important. I'm going to talk about attitude. Attitude is everything. I am here today because of him, first of all, but I'm here today greatly because of my attitude. My belief in regards to attitude is it determines your latitude, right? My choice of attitude is humor and laughter. And for those who know me, know that you're going to laugh if you're around me. I'm sorry if you're in a bad mood, but you're going to laugh. That's what's gotten me through. And we're all very different, but that's a big component. Your attitude is going to determine whether you go up or whether you go down. Going to keep going. Limited options for me. So once things went south, and I'm going to kind of go around a little bit. So for 4 years before COVID, I was about 50% lung capacity. And what that means is if you take half the breath, that's all I could get. I couldn't get any more. I didn't tell most people, only my family and close friends knew. It was none of their business. My mind was, this is just a personal thing, that I'm going to figure it out. I'm competitive, I'm going to figure out how to get through this thing, right? But if there were a set of stairs, I'm looking for the elevator. I just had to do everything a lot slower. Did you guys catch how I said slower? Slower than I had been. But most folks didn't know. Where's the elevator? That's all I really cared about. Limited options. My lungs went from 50%. One day, right about the time of COVID starting, had nothing to do with COVID, they just dropped. My pulmonologist told me that, Gary, if your lungs ever drop, that's it. We got to get listed. In my mind at that time, it was the most terrifying thing I'd ever thought of. Who thinks of that stuff? It's not going to happen to me. Well, guess what? It happened to me. So, all right, this is the deck, the cards that I've been dealt with. What's your game plan, Gary? What are you going to do? So my choice was to stay positive, as I mentioned before. My quality of life had slowed down greatly. I knew that that's how it was going to be going forward, but I was fine with it because I'm still here. I actually had 2 chemo infusions from a different study. One of the 7 doctors I was seeing and still seeing at this time had some success with one of his patients with chemo. And for me, had those infusions, it worked, but it didn't work as quickly as we were hoping. And even then, it would just be a Band-Aid. At some point, I was going to need to do something much more effective than that. But I was in a very dark place. That's a big part of it as well. So as mentioned before, I am a PFF ambassador from the class of 2024. And that's one of the things that I'm very transparent about, being real about what's going to happen. I'm not an expert. I'm not a physician. It's none of that. But I'm just going to tell you what happened to me because these are some of the things that will definitely happen. Not all, but some in your case. At the same time, my mother was dying. We were both dying at the same time, and I was taking care of her. So a lot of things were going on. I was working full time. Limited communication. I mentioned before, I didn't tell anyone really, but I knew what I had to do at this point. Got to get listed. The process of getting listed, the doctor went through it. Not going to touch on that, but it's a very rigid process. Had to stay committed through it all. Positive attitude stayed throughout the whole process. My prayer life was strong. That's always going to be strong, regardless. Still is. That hasn't changed. What's interesting is you see the support groups. There was the PFF program. There were the monthly support calls. This is pre-transplant now. There were my internal circles, right? A couple of different ministries at my church. So I had those in place, and those were very critical, and they still are. I had a private journal, and every now and then I go back to that journal just to remind myself of where I was versus where I'm now. I'm not a person that believes in tattoos. My body is my temple. But every morning, I have this 8-inch tattoo north and south of my chest that I see every morning. And it reminds me of where I was versus where I am now. So I am so thankful for that tattoo that I'm still here today. And focusing on tomorrow, it's one day at a time. He woke me up one more time. That's my attitude every single day. He woke me up again. That won't stop. November 30th, I received a call. It's interesting because November 5th of 2020, I got listed. So less than a month, the phone rang. And I happened to be at rehab on a recumbent bike at the hospital that I ultimately the next day had the transplant.
Oh my gosh.
So he was all over this, and he continues to be all over this. I thought, because I'm pedaling on the recumbent bike, my coordinator's phone rings, I stop pedaling, I get the news, my doctor says, Mr. Johnson, I have a set of lungs. Do you want them? Literally, just like that. Many of you may remember the TV show called Punk'd. I thought I was being punked. I'm looking around for the cameras, like, this is a joke. No, it was real. It actually happened. The dream came true, and transplanted the very next day. Just wanted to share some pictures that mean a lot to me to this day. The upper left corner, that's the amount of medication I take every single week. That's what I ingest every single week. Top middle, that was me in my induced coma. Top right, that was me getting home, being released from the hospital after 11 days. The bottom left, I mentioned that I and my wife are very involved in different ministries at our church. One of them is the couples dance ministry. I had my transplant December 1st, 2020. This was 2 months later on Valentine's Day. Valentine's Day was on a Sunday, and this is my church. Deep COVID now, don't forget. There were 6 people at church that day. We have a church of about 3,500 members. My wife and I, our pastor, the music director, one singer in the choir, and a production person. And we danced to a song on Valentine's Day. A few months later after that, maybe 4 or 5 months after that, maybe 6, parasailing in Myrtle Beach. That's my wife and I. My ankles look like elephant ankles, but didn't matter. That's part of the process. We did it. Positive attitude. Tomorrow's a new day. Looking forward, never looking backward. Got that humor going. I got people dying laughing, but I'm going to live. And it's so interesting. One of the things we talk about, that 3 to 5 year life expectancy I mentioned before. I've always believed from the moment that I heard that, well, those statistics have nothing to do with me. That's everybody else. They don't know who they're dealing with. They don't know, because I'm his and he's got me covered. And I stand here before you today as that still holds true every single day. Bottom right was my first anniversary of my annual checkup at an Over Fairfax hospital. And those 4 or 5 members there are some of the employees who were there the year before to be with me during my transplant process that are still there. Every year at my annual visit at an Over Fairfax hospital, I'm able to grab as many employees as I can to take such similar picture, just to remind me and to keep me positively motivated forward that I'm still here. So I'm thankful to be a part of this opportunity to speak with you all today. And my goal then and now and in the future will be to help, right? Any way possible. My job from here on is to motivate and help others. Thank you.
Thank you, Gary. That was beautiful. Dr. Trindade and I both agree that that's a relatively small number of pills for a week, so you're doing pretty well. And that neither of us would let somebody do that skydiving thing that you're doing there. Rule breaker. Don't tell your doctors if you're going to do that. Okay, we're going to finish with Anita before we open it up to questions and discussion, so thank you.
Thank you. I'm so happy to see you all here, and I'm actually humbled to see this many people dealing with some piece of pulmonary fibrosis and possibly transplant. I was diagnosed with hypersensitivity pneumonitis in 1995. It was the year I turned 40, and that was my big 40-year birthday celebration, was that I was hospitalized twice with pneumonia, and a wonderful physician, wonderful pulmonologist, determined quickly that it was more than just pneumonia. And so I went through a number of tests, and like everybody here, and I was told that I had a 3 to 5 year prognosis. At that time, there was no medication, not even experimental. I was on supplemental vitamins that some research was being done on, and that was primarily it. Though I tried a lot of different medications related to RA and other types of immune suppression. And those 3 to 5 years, I was told there was no cure other than transplant. And I worked in healthcare my entire career as a medical social worker. And yet, I had never worked with transplant, oddly. I worked at several different hospitals. And my initial reaction was, absolutely not. I will never have a transplant. You know, I was 40, my kids were 10 and 12. I was in the process of, my marriage was ending, and I had a life to live. I worked full time, I taught school at night. There just wasn't time for it, and I think that's exactly what you said, Karen. There just wasn't time for it, and that rang true for me. Because people have said to me, how did you cope with it? And I don't know, I think I just did one foot in front of the other and lived my life as best I could. And I look back and think, not one person ever, and I had 3, I went to National Jewish, I went to another medical center for opinions, and no one used the word terminal with me. They said 3 to 5 years, but that's a little more vague than terminal. So my 3 to 5 years actually lasted for 20. And people have said to me, oh, you must have been misdiagnosed. And it's like, nah, I don't think so. I had an open biopsy. Like I said, I saw 3 different practitioners. And I had what everyone has referred to as a stair-step decline. So I would go along and do okay, and then something would happen, and I would go down and go along and go down. So I lived a relatively normal life, except for 2 things. One, I was short of breath, increasingly over the years, and the other was my cough. And my cough was horrid to live with, horrid to have around other people who looked at me like I had leprosy or something. And yet it continued, and my kids grew up as I prayed every day to get them through school and through college, and I did. And I agree absolutely with you, Gary. I did not do that alone. That was God's hand. But then, you know, when it was 20 years, I had prayed for 20 years, and it was 20 years, I wanted more time, greedy as I am. And then I was, as was mentioned, I met a wonderful man who's here in the audience, and I was married to him 2 months before my transplant with oxygen, though I took it off for all the pictures. And I was a grandma for the first time, one time, and my life was like wonderful, but I was getting sicker. And I had to stop working because of my cough, and because by the time I went to the hospital with emergency, I was on 30 liters of oxygen at home. And I was able to be on this ICU level oxygen because my husband is a retired pediatric cardiologist who was familiar with transplant. Another blessing from God that I do not minimize. And so he had an ICU set up in our house for me. So when I was taken by ambulance, because I couldn't breathe on 30 liters, I was taken by ambulance to the ER. I think they were dazed and amazed that I was on that at home. And it seemed quickly pretty evident that I was either, to me it's felt this way, it seemed like I was either going to die or I was going to have a transplant. Oh, and I completely forgot to tell you that maybe 6 or 8 months before my last venture to the hospital, my family had urged me, my kids, my husband, my siblings, begged me to get on the wait list. And I was still saying, no, I don't want to be an invalid. I had this picture of transplant people, frail, wan, skinny, weak, in a wheelchair. Where that came from, I have no idea. But I kept saying no. And then when they were so earnest, and I had this wonderful life, I said, I want to live, I think, because I didn't want to live sick. And so I went through the process. I was admitted after it had ended, and I was admitted to the hospital through the ER 6 days after I was waitlisted. It was approved for the wait list. And then, while I was there, I was given if we have a lung, do you want it? And I said, I think so. And then they started talking about a ventilator or ECMO. And I was like, no, I don't want either of those. And God's hand again, a doctor walked in and said, we have lungs. But they've been rejected at 2 other medical centers because we don't have enough medical history on them. Do you want them? And I was so close to dying. I think I was within days of dying, that I said, yes, let's do it, because the risk seemed so small at that time. And so I knew with certainty that I wanted to live. And that was my overriding. Did I say I was 62 then? I wanted to live no matter what. And so we said yes. I talked to my family and said, do we need to resolve anything before? Because I didn't know if I would survive because I was so sick at that point. And I went to surgery. And that was 9.5 years ago. And I have had a tremendously successful, I hate to even say it because I feel like I'll jinx myself. I went to Catholic school my whole life, so I'm very superstitious. Excuse me. And I've had no problems with my lungs. I've had other problems that you talked about from other things. Skin problems, kidney problems. I mean, there are multiple, you have to be realistic about there are multiple issues that go along with a transplant. Some people say that it's trading one disease for another disease. And I'm kind of negative on that because after living with PF for 20 years, this seems much better. Now keep in mind, one thing I didn't tell you is I am a hypochondriac. So I get, a pimple on my hand and I'm to my husband, am I rejecting? Is this it? Is this the time I'm gonna go? I mean, everything sort of gives me a little moment of, is this it? And, God is gracious and it hasn't been. And I'm hoping to make 10 years. And to be honest, I'm hoping to make 20. That's my goal again. I'm looking for 20. So now I'm 71. And I never expected to be this old. I wish I had saved more on my retirement account. And that's really true. I'm not being funny about that. But I have a wonderful life. I do not use oxygen. I am not short of breath, other than just because I'm lazy. I do exercise regularly, and I have now 5 grandchildren, and I can only be grateful to God for the opportunity. And I even feel that way about the illness in so many ways, because I feel like I'm such a different person now than I would have been otherwise. And I see the world differently, and I see people differently. And I'm very grateful for that. So it is exactly right what both Gary and Karen said. This is such a personal decision, and only you know what is right. But it is definitely hard to make it until you really have to make it. Like sort of academically, for me, it was like, no, But then in real life, in the moment, I felt differently. And I feel absolutely certain I made the right decision. So thank you.
Thank you, Anita. I'm really interested in one of the comments you made there that about the trade of one disease for another. Those are words that I utter out of, I don't know, several times a week as I'm talking to patients that are considering transplant. I mean, in fact, I say the following. I say, it's a trade of one disease for another, one set of problems for a different set of problems, and even one risk of death for a different risk of death. And it's interesting to hear how that lands on somebody in the way that you told me. I will say that I also add that, but you never want to make that trade unless you're getting something better than what you have, or something that's not as bad as what you have.
That's well said.
You want to
That's
wait,
well
and
said.
you want to wait to make that trade, and so that's how I'm framing it a lot of times with
That's
someone
great.
who's maybe a little too early for a transplant. Boy, you don't want to make that trade yet. you
Yeah.
know, but
You
yeah.
know, I actually went through a period earlier this year where I felt angry at my providers, and my pulmonologist is here as a speaker, so don't tell him. But I felt angry at the docs because we talked so much about transplant and we never talked about the other side, about what life after transplant is like. And that's why I'm so glad that you're here, if you're even considering it or if a loved one is, because it was unanticipated for me. In 1995, there was no PFF. There was very little online. And so they couldn't even say, don't go online and Google, because I couldn't for very much. And we didn't have mentors then. And that's why I'm very invested in being a peer mentor to people, because I think you need to really know what's coming.
She's my mentor. By
Yes,
the way.
yeah. Oh, as if he needed mentoring, come on. He mentored me. So I think however realistic you can be without being like, well, you're still going to be sick, because it's not sick, it's living. It's living with, I hate to say the burdens, but issues. And sometimes it gets me down. It's not all roses, that's for sure. Some days are really hard. And every time I have a monthly blood test to see my creatinine, I get very anxious because of my kidneys, but I'm alive, and I'm active, and I'm still me.
Amen.
While we're waiting for others to ask questions, I'll ask one more. As transplant physicians, in talking to people that are waiting or getting ready for going on the wait list, we frequently talk about how important it is to be and to stay strong and to get stronger and to exercise and go to pulmonary rehab. And sometimes people look at me like I've got a hole in my head, because
Right.
how do you expect me to walk with all this oxygen and shortness of breath? Why could that be so important? Why do you want me to do that? And furthermore, I'll see someone the next day who had their transplant 3 months ago or 6 months ago, and they say, gosh, doctor, you weren't kidding about how important it was to stay strong. Can each of you talk about, or actually each of you, talk about how important it is to stay strong or
Yeah.
exercise or pulmonary rehab?
I'll jump in on that one. I mentioned before, I touched on the fact that my experience was during a time of deep, deep COVID. I see that as a blessing, believe it or not, because any of us who have gone through this process, we're doing all this. The world was doing this, right? So that was a benefit. But I remember a particular moment in one of my rehab sessions during deep COVID. I'm on oxygen. I'm in a very dark place mentally. I'm moving very slow, and they wanted me to get on a treadmill
Yeah.
with the mask on and the oxygen. I couldn't breathe with any of that to start with, right? So I put all, and I did maybe 30 seconds. They just wanted me to do 30. That's all I could do, and that was a struggle. But similar to what you said, you look back on those things now, and it's part of my conversation that I have with the folks that I support. A lot of things that I'll share with you very transparently will not make sense now. But I guarantee I've supported now 16 people. My focus is men because I can get through to them where the wives and the doctors can't. From Seattle to London, kid you not. When I first met all of them, they were pre-transplant. All of them have successfully had their transplants. They're still alive. And a lot of this feedback is exactly what you just said. I'm so thankful that you told me that and you were very frank and clear and transparent up front, because it's all real. Now, like she just mentioned, we're all still having pings and pangs and little surprises every now and then, but we're still here. And what you mentioned before is something I have said a lot in a different way. I transferred one set of bad issues for a new set of challenging issues. But I'll take the current issues every second of every day, because they greatly outweigh the challenging ones that I had pre-transplant. So that would be my take on it.
We have a question in the back.
It was good that humor came up. I think it's very important. There are people here in this room that yesterday or today have been victims of hearing my jokes. And in our pulmonary support group that I'm part of here in the Chicago area, I'm the designated closer with a joke and on our monthly meetings. I have t-shirts that I wear to doctor's appointments to say, from Monty Python, I'm not dead yet. But for Mr. Johnson, to paraphrase W.C. Fields, Iowa State University, back home we call that Ohio State University. But I do have a question for the doctors. Yesterday I was told we probably, before a transplant, do not know the statistics of the donor, like how old they are. Like if I decided, geez, that person that's donating is 65, 66 years old, I'd rather not get that transplant from that donor. I'm not going to know that. But the question I have for you is, are you now looking at the ages of people on the donors who are donating organs and saying, no, that's over an age limit that we want to accept certain vital organs from?
Yeah, so that's a great question. I think as I mentioned early on, lung transplantation is a relatively new field, and so, about 40 years old. And to be honest, I think, I was in kindergarten at the time when people got in a room and decided these are the criteria that we're going to use to decide if a donor lung's going to be usable or not, right? And I think a lot of that's now been studied over time, and there are some things that still hold true, right? Back then, and there are a lot of things that don't, right? So back then we never used donors who have hepatitis C because we know the recipient would contract hepatitis C and suffer all the consequences. Now we have great therapies for hep C, and we can treat that recipient, and now there's a perfectly good lung that's used. In terms of your question for donor age, we set up criteria that's somewhat arbitrary of 55, but there are a lot of studies showing that lungs that are older, donor lungs that are older, are just as acceptable. All the lungs that are utilized are imaged, and so, and as I mentioned, during the procurement, we do things like bronchoscopy and visual inspection. So I think we're learning a lot about what can be done and what can't be, and we're certainly pushing the barriers with great outcomes.
Yeah, and we appreciate that there is the experience in Europe and Australia where they tend to take older donors, and they've published really wonderful outcomes with that. So by itself, it shouldn't be a problem. However, we should take every donor in the context of the whole picture, and so, if there's a significant or moderate smoking history in the picture, if there's something on the chest X-ray or CT scan or bronchoscopy, and you can't believe all the data that we have about every donor when we're considering it, The age by itself should not be the determinant, but maybe the addition of several things on top of it would be a tipping point. Yes, sir, here. Yeah, we might need you to have a mic. Oh, we're gonna pass the microphone around, so we have someone with a microphone in the back, and then they'll come and get you. Yes.
Yeah, I'm 4.5 years post out of Ann Arbor. I'm a single. My question is about the Da Vinci robot and the progress for the FDA to approve the transplant using that.
I don't know a lot about it. I mean, I know there are centers, UCLA, I believe.
There's been some work done in Mount Sinai.
Or Cedars-Sinai, yeah.
Yeah, Cedars-Sinai.
So they're one of the leaders. I know NYU's doing it. One of our surgeons at Vanderbilt's certainly gaining expertise in that. I don't know the regulations behind that, but you know, it's being published on. There are good outcomes. The incisions are tiny, and so you know, we know that the old clamshells incisions lead to, you know, can predispose to infections and poor healing and what we call dehiscence. You know, there's literature that the smaller the incisions, the better the outcomes. So I think it's an exciting time ahead. I don't know if Dan.
Yeah, I think we're interested in learning anything that might be possible. The numbers of patients that have been transplanted by robotic surgery are really small. It's highly debatable still whether or not it offers a significant benefit. I mean, there's always a downside. It makes for a much longer surgery, and longer surgeries can bring with it, you know, sort of alternative problems that might not have existed otherwise. They still might be needed to open the chest in a patient who starts out with a robotic as well. So I'm not sure it offers all that great of an advantage, and it might bring with it some disadvantages, but like with anything, we will learn as some people try it and explain how it goes, and if it's certainly shown to be beneficial, then it would become probably more commonplace. I don't think there's an FDA approval process necessary for that, but I might be corrected on that. Over here.
Thank you all for sharing your stories. It's great to be able to learn. My wife is about to be placed on the list. We had a question for you on travel time for the lungs. So you say they could be flown into the center, and you know, typically how far a distance are they able to, and do you see a correlation between how far they've come and how long the patient waits to receive those lungs for success?
Yeah, so the advent of the composite allocation score, which is now 2.5 years into place, has meant that patients are getting transplanted a lot sooner, and you know, outcomes are better. The problem, though, is that we are traveling a lot further now. You know, most centers are having to travel. There's a report of, you know, a center in Boston retrieving lungs from Alaska, right? Fortunately, the technologies are now improving because we know what we call ischemic time, so the times that the lungs are without blood flow, it is not great. It's not good for these lungs. But I mentioned or alluded to the fact that storing the lungs at certain temperatures, different temperatures, right? So traditionally, the lungs were stored on ice, and so that roughly translates to about 4 degrees centigrade. And there's a lot of work now based on older work actually showing that 8 to 10 degrees centigrade, which is a little bit warmer, so that's about 50 degrees Fahrenheit, is actually a lot more favorable. So we now are able to store those lungs for a much longer period of time. And that means then that, you know, traditionally we'd ask patients to come in, you know, within 4 hours. So if you lived outside of a 4-hour zone, you had to fly in, or, you know, whatever it might be. And now there's just a lot more latitude and flexibility, which is great for patients and surgeons alike.
So it's the times you showed of how little some people have to wait to get lungs after they're on the list is fabulous. My wife is very short, And she's looked into this. You can Google all kinds of stuff and send yourself into a tizzy. But she says, she needs small lungs. How much does that add typically to the delay after you get listed?
Yeah, so there's studies showing that shorter people do have to wait a lot longer. There are things that, and if you take into account other aspects too, so not just the height, but blood type and what we call allosensitization. So have you been exposed to antigens from other people's cells? So people have received blood transfusions, people have given birth a lot, some women who've given birth a lot might be more allosensitized. So the amount of lungs available to them is going to be decreased. So if you take all of that into account, sure, they're at a disadvantage. Changes, so I mentioned that there's a new allocation system. So there are points awarded to all of those things. I don't know if you remember that pie chart that I displayed. So you get rewarded. You're at a higher priority if you're shorter, if you're allosensitized, if you're at a disadvantageous blood type. There are other things that surgeons can do as well. So if you're waiting a long time, we can do a lobectomy on the donor lung, so remove the right middle lobe or a lobe to have better sizing. So there are things that we can do in that regard.
Hi. I was in the caretaking session earlier this morning, and there was this guy who was a caretaker for his wife, and she got a transplant, and he was talking about, post-transplant. And apparently it's quite common that the person who received the recipient can get kind of like a Dr. Jekyll and Mr. Hyde effect and from some of the drugs and be pretty ugly. He said it does go away, but I was wondering if the three of you had any of that.
Yeah. You could ask my husband.
I was going to.
I did for sure. And I just talked with someone about this last night, and I know you have something to say, Gary, that I was such a different person, and no one said anything to my family about why. And even though my husband was a physician in the same hospital, he apparently took him a while to say it too. And my daughter was terrified that I was going to be this lunatic with new lungs. And but then once my husband said to her, there's some name for it, he calls it something kind of gross, but pump head, that's what he called it. But and it went on for like 6 days that I was surly and mean and things that I'm not normally. And but once she was told that and it would go away, they were okay. And it did, mostly.
Similar to what Anita just mentioned, yeah, well, my spouse is here too. It might be better to ask her,
Yeah.
but it's interesting because for me it was prednisone. I'm still on prednisone. We'll be on it the rest of our lives at the lowest dose, 5 milligrams. Going to be on it, but that's the lowest dose. Over the years, and you don't know what you don't know at first, right? You kind of become your own kind of test dummy, right? It changes your personality. For me, prednisone.
Oh, yeah.
There are times where you get to jump it up to 60 and taper down because there's some type of infection or something. Early in the game, I didn't know what was going on. I mean, we're basically hippies when we come out of our coma because we're on these psychedelic drugs, right? Once that stuff wears off, right, you're a different person. But for me, prednisone, no one told me that I call it you go crazy. You're not the same person. For me, I'm talking only about me. But my inner circle did not say anything to me. So one of my closest friends, we had just gotten back from, we took our 3 adult kids and daughter-in-law to Europe for 3 weeks. It was a delayed Christmas gift due to COVID. And I had an episode right before we left the States, and we didn't have time to do a colonoscopy. So they put me on a high dose of prednisone right before we left, and I went into a crazy cycle. And I didn't know at that time that's what it did to me. It happened again once I got home and a close friend told me, he said, hey, I'm going to tell you something, but I love you. You know I love you. I'm never going to say anything unless you know it's true. I'm here to help you, not hurt you. I don't know who you are. And I needed that. So what I did was, because I was keeping a diary, I mentioned that before, I looked at what was happening at certain dates. What were the consistencies? I'm trying to connect the dots. And in every single one of those situations, I went back to my inner circle and asked, and they all flooded me all the information they never told me. I was able to connect the dots. In each of those was 3 or 4 situations. They had increased my prednisone. And I was tapering down. It changes your mood. I was angry. I went from here to here, 0 to 60, because of nothing. But that's a reality. So now, I know that when certain things happen from a medical standpoint, I will prepare certain persons, let them know, hey, get ready. So yeah, it's a thing. One of the things too I'd like to share too that I've learned and I communicate with the people I support is I tell them that Dr. Tang was my surgeon who performed my surgery, my procedure, sorry. These are procedures, not surgeries. They're the best in the world. They're the best in the world. But they have never had this procedure.
That's right.
They cannot tell you what it feels like. I'm the expert on the other end. So I look at myself as a partner with my expert doctor to help fill the gap to communicate some of the things that will happen. So that's what I'll say.
We have time for one more question, and the session will have to end. I'm sorry, everybody, but yes.
Okay. I just want to say I'm so glad that you, Gary, and Anita have had your transplants, and you guys are doing great. But my question is for Karen. And there was a time when you and I were talking, and you told me you were not going to have the transplant. Mm-hmm. I was very disappointed, very upset to hear that. And I just wonder, how did your siblings take to your decision? What was their reaction?
I think, Sham, your question was, how do my children take it?
Not your children and your brothers, your siblings as well.
Brothers and sisters. Yeah. They know that this is my decision. And also, unlike what Anita had described and what Gary has described, I'm really doing fine. So they see it as not a desperate measure because I'm doing well, you know. I mean, I could tank one of these days, certainly. That's the terminology my pulmonologist has used when I've asked him about whether or not I should have ever bought that long-term care insurance. And, and he will say, no, you've been going along fine and you plateaued. And he said, but I sometimes see patients that they go along fine and then they just tank. So I'm hoping that won't happen, but I think, Sham, that's the reason they don't try to convince me of anything different. Now, if I was really ill and if I was on 30 liters of oxygen, I think their attitude would be very different. But they're fine now because they think that I'm doing just fine. Thanks.
All right, well, thank you for your attention and for our panelists. Thank you.